In this lecture, I'm going to illustrate with my personal experience on the importance of research and the clinical methods of methodology in research, and also a little bit about statistics and how to write a paper. Now, in the United Kingdom, audit is mandatory for selection to a senior house officer rotation, whereas basic research is mandatory for being selected for a registrar rotation in the UK. So before we actually start these rotations, they expect us to go through these trainings. And this is one of the basic science research which I had to perform in the United Kingdom. So it involved handling the neonatal rats, identifying, isolating the hepatocytes, incubating them with oxygen, and then trying to add various inflammatory mediators, and then demonstrating how the glutamine is able to help the cells recover from the injury. So research is very important, and it is kept in the high pedestal abroad. Premier institutes in India should be able to do basic science research. But simple audit is something which anybody can do. And what is the difference between a research and an audit? A research is something where we try to create a new knowledge. You test a hypothesis or a research question, and it may involve a new treatment or a placebo, like a comparative analysis. Whereas a clinical audit is a cycle. So you start with setting standards, and then the measured standards. So, for example, you are doing a biopsy for a particular condition, and then your method you can test, and then see whether that method is right, and then you can implement a change. So the audit is a cycle. You can even do it for a urine culture. How you collect a urine sample, you can audit, you can improve on it, and then you can implement a change. So audit is a cycle. Many times these clinicians ask, why should I do a research? We have always done this way, or our teachers taught us like this. The textbooks say this, and then it works well in our hands. So why should we change? But nowadays, for academic promotions and incentives, the Medical Council of India has recommended that at least 2 research publications have to be um, done. But not only that alone should not be the motive. You should also be a little altruistic and try to help the mankind. Because unless somebody does a research and then gives out the results, how can it benefit anybody? If you find something good, why not share the knowledge? So it can be a simple stitch to prevent a dislodgement of a catheter, or it can be a stenting technique during a pyeloplasty, um, or it can be a new operative technique, or it can be a modification of a existing operative technique. But unless you publish it, people will not be able to learn from your experience. So how do I get research ideas? This is a common question people ask. When we now subscribe to journals or we register for the journals, they come up with a pop-up. So when we start reading, then we suddenly find that a new drug has been researched already for one condition. So we'll get the idea that why can't we also try it for a similar condition? For example, this mirabegron was tried for neurogenic depressor overactivity in children. I get a question to myself, why can't I try this on valve bladder kids? So I start a research on that. So before you even start a research, there are certain basic questions you need to address, whether that is feasible. If you are doing a 1-year fellowship, then you should choose a correct type of research which will finish during that time. Then whether it is an interesting idea, whether it is a novel idea, or at least it modifies the previous findings. If nothing is new in it, the journals will not accept. And ethical considerations, it's really important in children, and institutional ethical committee approval is needed for almost all research these days in children. Also, you need to know whether it is relevant to the current literature. So if you want to publish your findings that your lab fundoplication results are excellent and you want to publish that, that part is already over. People have already published on lab fundoplications. So that may not have a much traction among the journals. So the PICO formula is an important step in formulating the research questions. So the patient, intervention, comparison, and outcome. So you need to know what patient population you are going to address, what intervention you are doing, or what exposure you are giving, and then what is the gold standard you are comparing with, and you have to define your outcomes. So why are we not able to do the research? The important reason, even in a big institute, why we are not able to research is because we do not keep the data. So if we keep on entering the data, then we are able to pick up a particular problem. For example, this is the data of the newborn children who underwent the posterior urethral valve fulguration, and we have the initial creatinine value and the creatinine value at the follow-up. So with this data, we can say that even in those with the nadir creatinine which was high, we could actually get good results. The other important problem with the conducting a research is lack of uniform protocol. So this particular protocol was published in 2003 in Indian Pediatrics from All India Institute of Child Health. This is about revised guidelines for management of antenatal hydronephrosis. So it recommended that all hydronephrosis more than 10 millimeter warrants an MCU, and then if that is negative, they need a renogram. So we religiously followed this protocol. We audited this and published our findings in 2018. And what we found was we are doing too many investigations. The number needed to treat was much more. So we have changed our protocol now. So we have now reported that only in the presence of hydroureter we will do an MCU, and only if the millimeter is more than 20 millimeter diameter we will do the renogram. So coming to the types of studies, there are multiple types of studies, but the most common studies we publish are case series and case reports, observational studies, and non-randomized controlled trials. Now, case series, I've got a problem. You may feel that this particular type of intrasacral sacrococcygeal teratoma is a rare thing, but when you look at the literature, there are already 20-30 cases reported, means the journal may not find it that interesting. On the other hand, if you treat a case like with a rare case with a new intervention, for example, we treated this renal fungal balls with the streptokinase. It was a single case report, but it still got published in the British Journal of Urology. Now, coming to the types of studies, the commonest studies we can do these days are case series, case cross-sectional study, case control study, cohort study, and non-randomized trials. So I will try to illustrate from our own series. Case series is the commonest which we can do. It is often retrospective, so that is the problem. So it lacks a uniform protocol and the acceptance rate is low. However, it can still get published. For example, this particular was the largest series of esophageal atresia with the right side aortic arch. It is around 12 cases only out of 475. So such a rare problem. So although it was a case series, it was accepted. Now this is implanted vascular access devices, chemoports in children. So this is the original article which was published in 2002. This was rare. That was just being introduced in the world at that time. So that got published. But now if you want to publish the same retrospective series, it will not work because we are doing chemoports on a everyday basis. So before you even start a study, you do a thorough review of literature. It may help to drop the idea altogether, or it may help to alter or refine the study what you're planning. So ask yourself what is interesting about this, whether it will actually negate or refine the previous findings. And then in the methodology, you have to be absolutely sure to include, have a clear inclusion and exclusion criteria, and then you have to work out the sample size, and you have to define the outcomes. Analytical cross-sectional studies are done on the same period with an exposure or no exposure, or an intervention versus no intervention. So this is one study where we looked at functional outcomes of early versus delayed pyeloplasty in children with the PUJ obstruction. So that is one kind of this is another study where we looked at the comparison of extravesical and intravesical. So two different techniques over a single period of thing was compared. Now, cohort studies and case control studies. These are two different studies. In a cohort study, you have two groups, and then you expose them to a different particular intervention or a medication, and then you assess the outcome. So you can express this as a relative risk of in a cohort study. That's more of a prospective study. Whereas a case control study is a more of a retrospective study where the outcome has already happened. Then you go back and see whether that was due to a previous exposure or an intervention. So this is a study where we looked at the compared outcomes of F0 diuretic protocol versus F -15, F +20. So this was prospectively assessed how many patients were having difficulties or indeterminate studies. So we looked at the protocol and how effective it was. And this is a study where we looked at the stricture rate following PUV fulguration, and then we compared the two different techniques of what we had used earlier, like uh, whether we used a diathermy or a cold knife. So this is this can also be called a retrospective cohort study, but it can also be called a case control study. Now, experimental studies are like a placebo versus drug, or a drug versus drug, or an outcome comparison between a drug versus no drug, or a symptom improvement before before and after a drug. For example, this is the case where the paper where we looked at the outcome of the influence of intramuscular testosterone in improving the functional and cosmetic outcomes. This is a prospective randomized study. This is another study where we looked at the effect of tolterodine on non-neurogenic voiding dysfunction. So what can go wrong in a study? You have to be aware that there are multiple biases that can be there. Observed association can be by chance, and the power calculation is important upfront to make sure that you have enough sample. Or it could be due to errors in data collection, errors in case selection, errors due to selection bias. A blinding is a method to reduce the bias. Or it could be due to influence of an additional coexisting factor, like a confounding factor. We often see during this COVID outcomes, we see that some countries have better outcomes. That maybe just simply because they have less morbid patients or younger patients. So these are all confounding factors. Now, reviewers only grill on methodology. I will just illustrate how this is important. This particular study, when we about the testosterone, we had to describe who was selected, who was excluded, what was administered. We had to say that it was an intramuscular injection and not a topical agent. And then how we respond to assess it, we assessed it the glands width. Then who performed the surgery? Was it the same surgeon? What was performed? What was the procedure? Was it the uniform technique? How was the outcome defined? How did you assess the functional outcome? How did you assess the cosmetic outcome? And then what statistical test was used? All of it you have to um, tell them. So how to design a study? What are the tools to analyze? And how to write a paper? So these are the important questions people often get worried about. So in the design, you have a dilemma between whether the ideal question, what you should post, and the data you can access. So before you even start, you write down the objective of the study. It should be like a single sentence or two sentence. I want to find out whether the laparoscopic pyeloplasty is superior to open pyeloplasty. So that is a clear objective. Then you translate objectives into testable hypothesis. So that means, what are you testing? Are you testing the success rate? Are you testing the time to discharge? Or are you testing the duration of surgery? Or are you testing all of them? So you want to say that these things are um, improving with particular technique. So you have to list the potential findings and then resulting conclusions. Now, observational designs, as I said earlier, it can be a case control, or it can be a retrospective cohort, or it can be a prospective study where you expose them to a particular agent. For example, this COVID vaccine versus some other sham vaccine. So that is a kind of a prospective study. Now, when you do a prospective study, there are a couple of important things you have to know. One is an odds ratio, other is a relative risk. So the odds ratio is a ratio of two odds. For example, you're doing a prospective study, your odds of developing a side effect is so much with this particular vaccine, and then your odds of having a side effect is that much with a placebo. Then how do you compare that odds ratio? So that you compare it by doing this calculation AD by BC. So here you should remember that the disease or the outcome, not just the disease, the outcome is written on the top. So that is something which you have to remember. Okay, so the outcome is always on the top, and then the exposure or the intervention is on the side. And then you write this A, B, and C, D like this way, and then only you do the calculation. Okay. Now, relative risk is something which is used for retrospective cohort studies and case control studies. So for example, your relative risk of stricture was this much with uh, in the particular group where you used the diathermy, and your relative risk of stricture was that much with your uh, no diathermy or a cold knife. Then you can say that the relative risk of one versus the other is by A plus B by C plus D. So even here you have to write the outcome in the top. The outcome here is the outcome of stricture, and here this is the exposure, whether it's exposed to diathermy or not diathermy. So that kind of is a study. Now clinical trials can be a crossover trials. I am not going to tell exactly about the entire details, but the participants are screened at the time of entry for the entry criteria. So there is a clear inclusion and exclusion criteria. They are exposed to a treatment or exposed to not exposed to a treatment or exposed to a placebo. And there are some crossover trials also. I won't go into the full details of that. But one of the important thing, as I said earlier, you have to think about in the methodology is you have to make sure that what your difference or association is not occurring because of chance. So it occurs by chance when you don't do a power calculation. Then measurement bias, when you measure it wrong or you are already influenced, the blinding is a way to take care of the measuring and confounding bias. Selection bias is basically again an important step, as randomization is an important step for avoiding a selection bias. Now in the internet nowadays, we are living in a golden period. We have a lot of internet tool. So when you want to do a study, do a sample size, so we have this sample size tool. So for example, you want to compare open versus laparoscopic reimplant. So you go into this tool and then say that you have to know from the literature what is the success rate. So for example, open reimplantation has got a success rate of 95%, and lap reimplantation has got a success rate of 80%. Then you enter that and then say calculate. It says that you need 150 patients. So that is the sample size of 75 in group 1 and 75 in group 2. That is a group 1 and group 2. Like that. Now let us look at some other example, open versus lap pyeloplasty. So here this difference was like a 15% difference. So that is why we have this number. Now let us change this. So this open pyeloplasty has got a success rate of 95%. Lap pyeloplasty has got a success rate of 90%. So if you enter those numbers, your values also change. From 150, it has become 800 patients. So you need 400 patients in each group. So that means the wider the difference between the groups, the smaller the sample you need. Now coming to randomization, the randomization tools are also available on the internet. The GraphPad is the commonest software I use. So you can go into this calculator and then enter the randomly assigned subjects. So the 150 patients, you enter 150 and then put it into two groups. It will give you like this, and then you can say that it is randomly assigned into lab versus open. So you can alternatively, instead of doing it alternatively, you can do like randomly. So there is no selection bias. Now, simple statistical tools. I want to illustrate one example with this particular study which we did and published in the year 2004. This is a surgical risk factors for Hickman catheter sepsis. So we had a catheter-related sepsis of 9%. Now, what is the confidence interval for this 9%? So that depends on the number of cases we studied. So we go into this GraphPad calculator, then enter the confidence interval of a proportion or count, and then we enter this 9 and 95. It tells us that the confidence interval is 8 to 22%. So this particular data we have to provide whenever we give any percentage. Now when you compare proportions, the chi-square or Fisher's exact test is the commonest test which we used. Now in the same study, we had two different techniques. One was a no-touch technique where we used double gloves and then a lot of betadine swabs, and then we never touched the handle, the catheter. The other technique where we did not follow any of those precautions. So we wanted to compare which one was better. So among the total 9 infections, we had 6 in one group, 3 in the other group, and this was equally divided. So we have to enter these details here. So that is called a 2 by 2 table, and here we again I said the outcome is here. So the infections versus no infection is here. The outcome is always on the top. and these are the two groups. The one thing you have to remember when you enter is the total is on the last. So the total is not entered here. You enter the infection in this group A, no infections in group B here, and the total is automatically calculated. That is how you should enter. Now you go to graph pad prism, choose Fisher's exact test. Why we are using Fisher's exact? Because one value is less than 5. If all the values are above 5, you can actually use a chi-square test. But even there you can use a Fisher's exact test, which gives a better result. So this is called a 2 by 2 contingency table. So this is analyzing a 2 by 2 contingency table, and then we enter these numbers what I've shown, 6 and 41, 3 and 45, and then it calculates itself the total numbers. You just check whether the total is correct. So 47 and 48, here 47 and 48, and then it tells you the p-value. The p-value is 0.3. That means there is no significant difference. Now people just get jittery when they say no significant difference. It's actually, here we have proven that taking extra precautions by putting double gloves and not handling and putting a lot of betadine swabs is not needed, because there's no particular difference. So this is a lack of significance. So lack of significance also is sometimes useful. So types of data, the data can be a categorical data. Categorical data means you have infection, no infection, success or failure, like yes or no. So here you express this as a percentage, or it can be a continuous data. For example, serum levels or kidney function, the GFR rate, anteroposterior diameter. So this kind of continuous data means you have to describe them as a mean and standard deviation if they are parametric, if they are normally distributed. What do you mean by normally distributed? That means they form a bell-shaped curve. If they are not normally distributed or skewed data, then you have to express them as a median and interquartile range. So that is a non-parametric data. So the type of statistical test you use depends mainly on the normal distribution or a skewed distribution. So there are tests to find out how this is also there. So I'm not going to the details, but there are a lot of normality tests available. Now, mean and standard deviation are something which you can easily find out by entering the data in an Excel sheet. So this is a two set of data I've entered here. So what I have done is, so you select all this data and then go to the function in the Excel and then enter that average, you get the mean. And then you go to the function, instead of average, you choose more functions and then type standard deviation. Then you get STDEV, that one. So, and then you choose that and then enter, then you get a standard deviation of 2.06. So that is for this particular set of experimental data. So this is a data which I have typed here. This is not a real data. I just want to try and show. So here we have a group A, 14 numbers are there. A group B has got 12 samples are there. So here the mean is 4.3 and then 2.06 is the standard deviation. And here it is 7.5 and 5.7. So we want to compare how these two different. In real life, you may have this kind of findings. For example, a kidney function before surgery and kidney function after surgery. So that kind of values you will have. So if you want to compare that, then you go to this graph pad calculator and go to t-test for to compare two means. Then you enter what kind of data you have. You enter mean, standard deviation and number. And then in that you enter this particular number, whatever we have. So we have a mean of 4.3 and then 7.5, which you entered. Then a standard deviation of 2 and 5, which we have entered. Then the n, that is the number of patients or samples. So we have 14 and 12. So once we enter that and then say calculate, it says the two-tailed p-value is 0.05. So that is kind of borderline significance or not significant. So that is because the sample size is very low. If you have the same sample for around some 70 and 50 patients, the difference will be significant. So that is the usefulness of a significance. So a student t-test is used to compare two means. So here in this study we have used in a pelvis cortex ratio, an early marker of success rate. We have compared the mean ratio of that ratio before and after pyeloplasty. Here in androgen receptors after hypospadias, we have compared the mean H score before and after hypospadias. So in this study again, Utility of ultrasound elastography, we have compared the mean shear wave velocity before and after pyeloplasty. So this is our examples where you can use a student t-test to compare the means. So if you have a proportion like a percentage, categorical data, success or failure, use chi-square test or Fisher's test. If you have mean median like a continuous data, then you have a student's t-test. That is for your parametric or normally distributed data. If you don't have, if you have non-parametric data, then you have to do a Mann-Whitney U-test for 2 groups. If there are more than 2 groups, then you have to go for one-way ANOVA or a Kruskal-Wallis test. So these are all done using SPSS. But most of our work, we are using this and this. And for this simple test like a Fisher's test and independent student t-test, we do not need the SPSS software or a statistician. So we should be able to do that. Now coming to testing the usefulness of a test. For example, we are doing an ultrasonogram. We want to say whether that ultrasound is effective, or we want to do a serum marker, for example, a C-reactive protein, or a particular kidney function test as a marker to detect a CKD, a creatinine clearance as a CKD. So we want to know whether the test is a useful test. So for that only we use the for these things, positive predictive value, negative predictive value, sensitivity and specificity. So here again you have the outcomes here. So whether the patient gets the disease or whether the disease is not, and here whether the test is positive or test is negative. Now for example, I will give you an example here. Ganglion cells are absent in the appendix. That means the test is positive. So that patient has got a true positive, means he has got a Hirschsprung's disease. So you study 100 appendix and then find out that around some 50 of them have ganglion cells. Out of them, 20 have this true positive, means they have Hirschsprung's disease, countered by other methods. So that's a gold standard. There must be a gold standard, must be your full thickness biopsy. So you are testing the ganglion cells in appendix as a usefulness of that particular test against the gold standard, which is a your full thickness biopsy. Now coming to ROC curve is something where you find a cutoff for a diagnostic test. For example, I told you have the kidney function test for a GFR or an anteroposterior diameter of the pelvis. So you want to find a cutoff. For example, this particular study, we wanted to look at the postnatal management of bilateral grade 3 to 4 uretropelvic junction obstruction. So we wanted to know what is the kind of cutoff where the kidneys are improving. So whenever the AP diameter was more than 25 or GFR was more than 35, then we found that the opposite side of that bilateral PUJ was automatically improving. So these are all some kind of cutoffs we can find out using an ROC curve. Now coming to the other important topic, writing a paper, how to start. Catchy title is a key, we all know that. But very important thing is you have to read the author's instructions. They may have crucial information on the word limit, the limit on the number of images, all those things. And you have to provide that information in the title page. Now in IMRAD format, we all know that each article has got an introduction, method and results and discussion. So you should be able to decide what you want to write. So the introduction is usually made of 2 paragraphs. The first paragraph describes why you are doing the study, what was already there in the literature, what is lacking. Then you are in the second paragraph, you are telling what you want to study in that particular study. And in the second paragraph or third paragraph, you are ending with, in this particular study, we want to test this hypothesis that a laparoscopy is superior to open surgery. So that kind of statement where your clear aim should be mentioned in the last line of the introduction. And in the methodology, I have already discussed in detail. You have to tell exactly how you are selecting a patient, what intervention you are doing, you have to describe it. Then you have to give the inclusion exclusion criteria, how you are going to measure the outcome, then whether it is a blinded, whether it is a prospective, all details you have to provide in the methodology. In the results, you have to tell clearly like what exactly you have found, and in the discussion you have to establish why this particular finding is useful. So in the first paragraph, you describe what you have found, what your study has found. In the second and third paragraph, you describe what others have said earlier, and then from based on that, you can kind of come to a conclusion where with this particular finding is different from that study, or this finding is similar to study. Then you also have to add a line on the limitations before you conclude. So you have to write that this particular study is limited because we have studied from multiple centers, or so many surgeons were involved. So those are the limitations you have to mention clearly before you conclude. So in the introduction, you are selling your idea, what is known, what is not known, what is your aim. And in the methods, you have to provide the full details. And in the results, you have to let the data speak for itself. And in the discussion, you have to discuss the relevant literature. And you have to tell what is your inference based on the findings without extrapolation, and admit the limitations. So each journal, as I said, has a uniform format. Before finishing, you have to tell about that the institutional ethics committee statement, then funding, and then conflict of interest statement has to be there. The references have to be in the Vancouver style, or whatever style the journal wants. And then figures and tables have to be very clear. It should convey the message. And then legends also you have to add separately. These are all separately given. This is not part of the manuscript. And then a copyright statement and cover letter. So the illustrations, the illustrations, although have to be catchy, it has to be simple also. For example, in this paper on pelvis cortex ratio as a marker for success, what we wanted to establish was when we use the antropelvis diameter alone, only at 1 year we found a significance. Whereas when we use the pelvis cortex ratio, we found a significance at 3 months itself. So although it is a simple bar diagram, it tells you that using a pelvis cortex ratio, you are able to predict the success at 3 months itself. Whereas when you want to use the just AP diameter, you have to wait for 1 year to predict that the patient is succeeding or the pyeloplasty is succeeding. So this is a better marker than this. That is what we are trying to illustrate with a simple diagram. Now this is a box plot. A box plot is used when you are describing a non-parametric data. This is a median and interquartile range, and a curve. This is a trend curve. These are all used when you are describing a trend. Now, when you're doing meta-analysis, you have to use a funnel plot and a forest plot. I am not going to the details of this. Now, coming to the references, reference manager, citation manager is an important thing. It's very useful, and Mendeley reference manager is what I use. You can actually put them into import your references and then have them all in little your own folders. So what happens is when you start when you write an article, you go to one particular point and say insert reference, and then choose the name of the author, first author, and then say insert. It inserts, and then it also formats in the exact style that journal wants. For example, here the style is there. You can choose the type of the journal. Now, when you submit the paper and the paper comes back saying that we do not want this article, you want to submit for another journal, then the entire formatting goes away. Whereas when you have this Microsoft Word with the Mendeley plugin, then you can immediately reformat in no time using the Mendeley's software. Then choosing the right journal is important. If you want to send a paper, a pediatric paper to an adult journal or the vice versa, it's not going to work. Common reasons why the papers get rejected are it's either poorly written or not as per the journal requirements, or the research question is not clear. So a lot of the PGs do start a thesis without a clear aim, and then when they start to publish their thesis, this is what happens. They never had a research question to start off, so they cannot synthesize a relevant extrapolation of their data. So poor methodology, the results are not valid, or the extrapolations are not valid, and no clinical application or not a new idea, or it is out of scope of that particular journal. So those are the reasons why papers get rejected. Of course, the journals too wait for a right article, and I won't get frustrated if a paper is rejected. You have to keep on persisting, use the reviewer's comment, and try to improve your article. Sometimes I've had this reviewers comment which are longer than the article I wrote. I wrote four pages article. The reviewers comments are 8 pages. I shouldn't give up. You should keep improving your article and then send it to another journal, and then it will always get published. Impact factor of the journal is variable. It all depends on the reader base. So a Lancet has got a 60 of impact factor, but other journals like very important journals in our study group like Journal of Pediatric Surgery still have low impact factor. That doesn't mean that they are bad. That means that the reader base is highly super specialized and very little. But if there is no impact factor, like a predatory journal where you have open access journal that they ask you pay for the publication, that is a bad thing to do. So if I get a CV with a lot of publications in an open access journal, obviously I'm going to put him a negative mark for publishing in such journals. Mendeley, ORCID and SCOPUS, these are all for the researchers. So you can register in ORCID and then all your publications start appearing. You can register in SCOPUS, you have an author ID there. Then in Mendeley also it keeps you accumulating your work. Your index is important when you apply for higher jobs. Like an index more than 10 is often required for the universities for a dean post. So like that, your index and citation index, everything is important. So I think we should is introspect all these things. We should think about how important to learn basic scientific research methodology. We should think how to design a study upfront. Then we should also learn basic statistical analytical methods, and we should also try to learn how to write a paper. These are all very important things for progression in the career. Okay, so thank you very much for listening to this lecture.